We look forward to your conversation on the submentum.
And I mean, there's so many interesting things and so many interesting cases, and we have even more for you. So I'm going to try to fly by and be a little bit fast so we can talk about everything. Just in anticipation of some of the things that we were going to be talking about. Again, this is anecdotal. I agree with you, Tom, that we need to do, and by the way, they're coming, larger clinical studies. There is an IRB in now with the FDA, so we should be having more of them. But topical exosomes with microneedling can be, again, because there's an FDA, this is not FDA-approved treatment yet, but a topical with microneedling can help. And this is on some of our scars that we can see some of this improvement. So I just want to show that for a second.
Can you mention what exosomes you use, though?
Which brand?
What derived from which source?
Mesenchymal.
Mesenchymal.
These are mesenchymal, yeah. It's CME, so I'm not going to mention brands.
No, just.
But this is somebody who had a severe laser burn, not done in my clinic, and was treated with microneedling and exosomes by our good friend Tom in my office. And you can see it makes a significant improvement. That's why am I not? Okay, it is advancing. Okay, good. So I thought it would be good to talk about the submentum because it's all about our necks. Patients are coming in, and they come in with a neck like this, and they want to have a significant change. And whenever we talk about the submentum, it's really important to really kind of understand. Next. For some reason it's not. Okay. To kind of understand which layer, because then you can determine how you're going to be treating the patient. And seeing that this is ASLMS, we want to be using minimally invasive. So, and also, is it a young neck? Is it an older neck? Is it a full neck? Is it because of fat accumulation, in which case we can do Kybella, surgical options. We could do submental liposuction or some technologies that we're going to jump into talking about. But also, there could be a deeper issue, and that can be because of the hyoid bone being low, our muscles sagging and not holding it up, and that's an area that we really haven't investigated, certainly from a non-invasive way prior. It's an area that we really don't even talk about. We're surgeons. Heda and I both cut and sew, and so we can kind of pull on that muscle to help to reposition, cut the muscles, stitch them. But how we modulate them, and even inherently how they're aging, is actually a new frontier that we're going to be talking about more and more. Next. Okay. And of course, the face is connected to the neck, so everything starts drooping down, and what was in the face does start to appear into the neck. So we have sagging of the platysma, we have the bands, we have acute fat accumulation, and also the jawline starts going down into the neck. Next. Okay, so the points that I was talking about, looking at from the side so we can really help interpret, looking at this MRI, and then you can see the anatomical next to it. You can see the accumulation of fat glowing there, but you can also, maybe it'll be easier if I point it out, there we go. We can see the fat there, but then we also are seeing this muscle here, this digastric muscle, and we can see the malpositioning of the hyoid bone, and there's another structure next that we'll be talking about. Next slide. That we'll be talking about that also can need some modulation. So here, these are the muscles of interest. You can see, we know that the platysma band is more superficially, but deeper, what we're talking about is the digastric muscle and a bit of the mylohyoid. And you can see if we have this kind of sagging, if we have this obtuse angle, when we bring it up, if we can kind of exercise it up, then we can reposition that hyoid and take that unfavorable neck and make it a more favorable neck. Next. Okay, so here's a typical, so I'm going to start with the most aggressive treatments. I am a facial plastic surgeon. In New York, people really want to look good. So this patient, what do? We do a facelift. And she's super happy. Everything that was hanging down below is now back up into place. And I'm going to point out, she's very pleased with the result. I'm pleased. I think she looks good. I'm going to point out one detail. and that is the submandibular gland. And that is the one other. So not only are we now talking about how we can maybe be modulating the muscles, the deeper, more intrinsic muscles, the position of the hyoid, but the submandibular gland, which is what we have, obviously, like our providing usually redundant support, like our sublingual and our parotid, to produce saliva. So what we really need to start considering doing next, and here you can see, as we age, what was up here as a kind of more tucked under the mandible is now starting to slide down and is also contributing and is also going to be one of the reasons why you're not going to get that result in the neck that you really want to be getting. Next. Next. So that's why sometimes you actually have to go for that resection of the submandibular gland, which sounds a little kooky when you tell patients. Next slide. But if they want a result like this, then you really do have to do, if they want that, and everybody, it seems more and more, I don't know if it's because of TikTok and Instagram, people want to be so super snatched that they want to have this negative space underneath, which, I mean, it looks great, so all right. But then you're really talking, we're not just modulating skin, we're not just modulating fat, we're going to be talking about how to maybe modulate muscle, but then even going to that gland underneath. Next slide. And you can see it makes a really significant difference. And next slide again. And next slide. This is like a grand reveal what I'm going to talk about next. Okay, so this is where we can start to use, and here we are at ASLMS, we're talking about technology. This is how we can start to use technology to make a difference with the tissues underneath the skin surface. So we can use subcutaneous RF with a percutaneous suspension suture. Next.
Okay, thank you for the handful of you who came back. Could we have the next slide, please?
This is crazy.
Yes, okay, no disclosures. Go ahead, and after that. So this is a bizarre case of a 50-year-old woman who was referred to me by a dermatologist.
I can't believe it.
She had had blepharoplasty 15 years ago, and she had blepharopigmentation with eyeliner of her upper and lower lids about 3 years previously. And the only thing that I could pull out of her history that sounded like anything at all was that she had recent bed bug bites. She stayed in a hotel someplace and got bed bug bites.
Oh, jeez.
So, I mean, it sounds crazy, but I just absolutely could not come up with anything else. So go ahead and show the next slide, please. So when she came in, basically, and those photos aren't great. The left photo, her eyes are open. She's looking up, showing the infraorbital incision from 15 years ago, which had been completely fine, developed hypertrophic scarring. When she closed her eyes, the blepharopigmentation, so the lower lid, she had blepharopigmentation and blepharoplasty scar about in the same place. So it was one big thick scar. In the upper lid, there was hypertrophic scarring where she had blepharopigmentation and hypertrophic scarring where she had a blepharoplasty scar. That crusty thing that you see on there, she'd gotten an intralesional steroid injection from the dermatologist who referred her a short time previously, and she said she got a bit of crusting from that. So that's what you're seeing. She'd received that injection probably a week ago. That's all she had was the one intralesional injection, and she got crusty, so they referred her to me. So the question is, I have no idea what's causing it. If anyone has any ideas, can tell me why someone 3 to 15 years later gets reaction of scars. I'd be love to hear that.
I think you said something quite interesting, that she had recent bed bugs. And what if there was a bite there and created, because the hypertrophy is recent, like all of a sudden, so clearly there was some inflammatory
The bites were on her trunk.
Right, but what if the inflammation landed in the scar area? I'm convinced we don't actually.
Hyperstimulated immune.
Yeah.
I definitely think this is a hyperstimulated immune system, for sure.
For sure.
And I mean, bed bugs would make this happen too. I mean, I think that's what this has to do with. And I think you can't underestimate what Yael just said, that this could have been a bite on the eye area that caused this. You know what I'm saying?
Yeah.
Or flared it.
Because she obviously had bilateral blepharoplasty, and the other side was fine.
then it was a bite.
As far as she knows, the bites were on her trunk, but can't say,
The crust was for what, you think?
was from an injection.
Ah, okay,
Yeah,
so,
she had an injection. That was not.
got it. That's not like she presented like.
And the bites were several weeks earlier. So it's, the timeline is, may be appropriate for that, yes.
Are there any other scars on her body that also disease?
No.
How about COVID?
I mean,
vaccine?
yes, but no. Yes, other scars, nothing else became inflamed.
What about COVID vaccine or COVID exposure?
Oh, this is before COVID. This is pre-COVID.
Don't you know we blame everything on COVID?
I know,
now?
right?
The vaccine.
I know.
I was going to be genius on that one.
Good question. But to that point, no antecedent URIs, no antecedent vaccines, all, no new products, all the thing. Well, she had, her eyeliner was
That's
tattooed,
bad.
yeah. So, and there's hypertrophic scarring where her eyeliner tattoo was placed, as well as bluff. So there were two scars in the upper lid, one at the margin, one in the eyelid incision, and just one in the lower.
I
Brian,
would
can
guess,
oh,
I'm sorry.
no, I was just going to ask, the left picture, the picture to the left, the first one, is that pre any treatment?
That is after steroid injection by her
okay.
dermatologist.
Okay. So that's why it looks a bit ulcerated.
Correct.
And then I would guess that she was using fake eyelashes per what you're saying in the audience with the silver headband, because look at how ripped out her eyelashes are. Unless she has trichotillomania, but what common things are
No.
common, she probably is using lash extensions. And so the glue might have aggravated the situation, but I think it was immune stimulatory to begin
Immune
with.
stimulatory, it was 100% immune stimulatory something. So
Right.
then, wow, what did you do?
Okay, so next slide, please.
Fake lashes.
Yeah, so, like, what the heck do you do? There really is not a whole lot of options. I mean, you can basically inject it or laser it. I didn't feel like topicals were going to make that much of a difference for her. And I ultimately did laser with laser-assisted drug delivery a little bit. So go ahead and show the next slide, please. And here's what I ended up doing. I used CO2. At the time, that was the energy that was on a luminous device, but fractional ablative CO2. I did a total of 5 treatments once a month. Next slide, please. And that's where she ended up settling down just fine. But a bizarre
Oh, wow, beautiful.
case.
Wow.
You really helped her, you know.
So it's better lucky than good.
I say luck equals years of experience, in my
But it
opinion.
was just a very unusual
Any-
presentation of late eyelid
comments?
scarring.
Comments, questions, quickly? We have one more case that was my case. Do people want me to present it, or do we want to leave? It's just a case. Should I present it?
Present.
Yeah, present. Might as well.
We'll do it quick.
Run over.
Any questions about this oculoplasty?
No, I want to
No,
go
no,
to
it's
yours.
got
Okay.
to be like a few minutes. We're over.
Yes, please.
If it didn't respond to that, I was certainly consider getting to the scholars to see if
That's a good idea.
Or eosinophilia.
If it were not responding, I definitely would have done it. And in retrospect, I probably should have done it before I started lasering, but that was on me.
Okay, so we're going to quickly do one case. Can you go back to Hirmand? Hirmand. Go back to the presentation before this one, I think, yeah.
If we're on lunch, we could kind of maybe keep going a little bit.
What's the name of that presentation? What's the name?
Hirmand. Hirmand. It says Hirmand. Heide Hirmand. It should be right before Dr. Beisman's. It's the speaker before him
Okay.
on
thank
the
you.
on the schedule.
This should be it.
That's functional. This is beautiful.
Yep, challenging aesthetic, that one. Okay, great. Let me see if I can do this. Okay, I'm in New York. I'm a plastic surgeon. I'm not a dermatologist. Only on my good days, people think that I'm a dermatologist. Yeah. And I'm oculofacial, craniofacial background.
So this is a eye case, although it brings all specialties together. I just thought it would be interesting. I'm interested in shape changes with aging and shape changes with surgery. I can't, let me see. Oh, here we go. I don't have many disclosures. I try to keep them under wrap. Let me see, gosh, sorry about that. Okay, so I thought this was an interesting case. It's a 28-year-old lady who, young lady presented 5 months after bilateral canthoplasties. It was performed via the upper eyelid incision access, and she has some related scarring, dehiscences, secondary healing, and her chief complaints were a change of shape of her upper eyelids. She said she doesn't recognize herself anymore, and she also had scarring in the surgical side. So let me see if I can. All right, so pertinent surgical history, as I said, canthoplasties. Her incisions had opened post-op. We don't know why. And she had a scar revision afterwards in October. These are actual timelines. And the incisions opened again. She said each time they looked well healed, then sutures were removed at between 5 and 7 days, and then spontaneously each time they opened. And then they healed by secondary intention. Apparently, she didn't get any instructions. So it's a combination of a difficult patient and some contextual information. We suspected perhaps nutritionally deficiencies and also unnecessary surgery perhaps, and also a complication after surgery. So here is how she presented on her initial consultation. So I'm going to show you close-ups. Attractive lady, let's see. I'm sorry, can you go next? Probably best. Right, so there's not a pointer here, but really the issue, it doesn't seem like a big deal issue, but if you look at her, and I'm going to show her pre photos, her issue was that she said she doesn't look like herself. Her eye shape has changed, and also she had gone to 5 doctors and they couldn't offer her anything. And the scarring. Can you go next? So if you look beforehand, this is her pre-canthoplasty. Question still remains why she needed a canthoplasty, which I think she probably didn't. Obviously, she didn't. but the surgeon chose the upper eyelid for an access incision, which is a very common. I do my canthoplasties and canthopexes from the upper eyelid, but I probably, in her, she would be the one person I wouldn't do that in. I'm going to stop here, and I'm going to see if, Brian, I know we discussed this out there, but I'd love to get your input, and also the other panelists or anybody who wants to comment on this. This is her pre-canthoplasty.
Yeah, I mean, these are really tough cases. One of the, I think, takeaways, when patients tell you they don't look right, or they look different or whatever, we're just meeting them for the first time. I think it's super helpful to really understand what it is they don't like, because some of the things that we might intuitively think need to be changed, they're actually okay with. And she's got complex eyelid anatomy. Her lid crease is obviously different. Her position of her lower lids relative to her globes is a little bit interesting. She's got a relatively short horizontal palpebral fissure. It's just not entirely clear what she's seeing, aside from the obvious. She's got this scar in her upper lid. Like, you kind of want to know, what all are you seeing? And sometimes when there's a bunch of things that aren't right, if you can fix at least one of them, you're done. And then they stop seeing the rest so much. So that's what I'd try to understand a little bit more about what
yeah, I think it's interesting you say that, because really the bulk of the problem solving here for me was to talk to her. I mean, we had to stop our whole operations, and just kind of sit with her, get her photos, and really try to have her pinpoint what she sees, what I see, what was done, the before, the after, to try to figure out what is it that, how is she perceiving this, the problem, so be able to offer her something. Anyone else? Tom? Janine? Anybody?
So
Yeah.
I actually have a patient, you were saying she had the surgery, I know she had the surgery elsewhere out of the country? or-
Yes.
Yeah, so I had a patient who had also wanting to get this foxy eye or whatever motivated her. Years before, went to Turkey and had some kind of foxy eye type surgery, and came to me actually a couple of years later, had bounced from office to office with a wound chronically opening in her. The excess was in her temples, in her hairline, and the wound kept breaking down. So I'm wondering if the same. So ultimately, I went in and fished whatever sutures were in there. So I'm wondering if that was the same issue here. Is that there was a chronic infection that was just creating this chronic.
Right. So yeah, so we discussed, oh, sorry.
And then what I would comment is, A, she didn't need it to begin with, so there's always that. Just the reality check.
Right.
And showing the patients and saying, what is it? How much? Do you know that surgery is not perfect? You could have this complication, that complication. But B, if you're going to do what you did and fish it out, or what you're thinking about doing for this patient, it's really important to have an adverse events from an outside practice, like literal form that they sign and that you scan into your electronic medical record that says, I went here on this date at this time with this doctor, and I had this procedure done, and this is an adverse reaction from that doctor. You don't want to be swept up with like a wide sweep litigation later when you're trying to help the person. So it's not even good enough for you to take photos when they first walk in the office, because they could, quite frankly, unfortunately, people lie. They could lie. So make sure you have them sign an adverse events from an outside practice form before you touch them. Then, I may not touch them anyway because I'm that kind of a gal, but at least you have that sign to begin with. That's really important. So, because you could be swept up in litigation for whatever later. Okay?
That's a huge super, and I'm definitely taking that as a note. Also, I want to announce that they are extending this session until noon and then doing lunch. So if we want, we can kind of stay and maybe have some discussions. I can give you the exciting conclusion to my talk.
Oh, that's perfect. So Janine, that's a really good idea. Of course, we don't have such a form, and but we need to do that
immediately.
But that's really, if there's one take-home message from this, I think that's that. So after really evaluating this, and as we were discussing, this would be the one person I would not approach from the upper eyelid incision for the surgeons in the room for either a canthopixy or a canthoplasty, even though that's my preferred route. To keep the lower eyelid incision shorter. Usually that's what I do, because her, not only is her crease is high, but also mainly because her crease is short longitudinally. So to reach her lower lateral ligament or retinaculum from the upper eyelid, you really have to extend her incision. So to extend her incision, the way they did it in a straight line, it just distorts the shape of her eye. So if this person had come to me, first of all, I wouldn't do a canthoplasty on them or a canthopixy, but also I would have a full disclosure and discussion with them that their upper eyelid was going to look a little differently if we did this, and they would extend their crease to some extent, and that scar may be visible. But in any case, we were where we were. And can you go to the next slide, please? And so with much trepidation, I just wanted to show you her, if I go next again, sorry. So this is her pre and post. So if you see, to drive home what I just said, what happened, the scar visually distorted the end point of her upper eyelid fold crease. Okay, so the reason, and this really was because we stopped everything and we started talking, I started talking to her at length. She visually does not recognize herself because now her crease sort of doesn't stop, but goes in a different direction, more horizontally. So next slide, please. So what we decided to do is to sort of do a multimodality and try to address the scar, the pigmentation aspect of the scar, the texture of the scar, and the fold. And I did counsel her that she hopefully will be better. There's no guarantee, but her crease, her fold is just never going to be the same length anymore. So she has to be prepared that she'll look more like herself, but never exactly the same. So she got pulse dye laser treatments to the scar erythema. I used the high G prime filler for her bilateral upper eyelids. I used the scar part of that horizontal scar and actually filled over it to create a fold, because the scar had flattened it, which is what you can't probably experience just from the 2D photos. 2 sessions of that to create an actual fold that's lateral to her own natural fold. And we did some microneedling with PRP at the parameters you see there. We did several sessions of that. So those are the dates, so you can see the timelines. She had come in November, now we're in March, and these are the procedures. And let's go to the next slide. Okay, so I'm gonna, can you go to the next slide, which is probably a close-up? Yes. So here you see her results. She doesn't have makeup on. I didn't believe it. After I saw the photo, I ran in there and I was like, can you take your makeup off? And she actually has no makeup. She really responded well. She's also younger. She responded well to the laser treatment. This is a low technologies that we were able to use to create that. But if, I'm gonna show her pre and post, and you'll see her fold is not exactly the same. The shape has changed to some extent, but at least it resembles herself. So I think by combining attacking the scar texture, the scar pigmentation, and the shape of her upper eyelid fold/crease, we were able to get something. I didn't actually expect these results, so I was actually shocked. I was truly shocked. I was like, I couldn't believe it, like my jaw dropped. I was like, oh my God. But I think, again, it's helping someone who's pretty distraught, and hopefully they learned a lesson, we don't know. Can you go to the next slide? So this is her, again, before and after, no makeup on the right side.
That's beautiful.
It's also her, you know, her response, her PRP must have been really good, because as we know, not all PRPs are. No exosomes. I have some things to say about exosomes. Next slide. And that one, and then every little bit helps. I think the high G prime filler was really key in extending that crease and creating a fold. And then next slide, please. Sorry, go next. There's an extra slide in here. Oh, sorry, too many slides. Next. So here's pre-canthoplasties, pre-anything, presentation in the middle, and then post. And if you look on top and the bottom, if I could show it in higher mag, the crease is a little bit longer, or at least looks a little bit longer, or the fold rather, not the crease. But she looks more like herself. She doesn't look distorted.
She's lucky.
Questions? Can you go to the next slide? I think that's it. I think actually that's the last slide.
I have a question, actually,
Yes.
as the
Can we go back a
non-surgeon
slide?
here.
Yeah, go back one
Back
slide.
just to see the before and after.
When we're looking at the before and after, what was the goal of the original canthoplasty? What was she trying to achieve?
She was trying to be more attractive. I think there is a little bit of element of body dysmorphia also going on now that I've gotten to know this patient. So when she actually wants to have surgery again, she's like, can you take the canthoplasty sutures out? And I showed her photos, and I say,
Why?
you may have an issue, that's why your stuff opened, but it's not manifesting right now. Why go in now and do it, right? So, and I think she's actually now settled down.
So let's look critically, because also I think we're all wondering why did this rabbit hole start?
Right.
And you know, if you look at the lower picture, I suppose, I mean, it's hard in the middle picture because she's still swollen and the wound is broken down. But you know, I suppose there is some correction to her lower lid position. A slight less rounding, maybe some improvement, but I think that really is fundamentally what we're all kind of questioning
I don't
here.
know, because she's also looking down a little bit in the top photo. I mean, those are not my photos, the top photos. So
Yeah.
you see that she's looking down a tiny bit.
So I guess the question really would be, would any of us have touched her in the beginning?
I don't know, Brian?
The juice ain't worth the squeeze. No way.
No way.
I wouldn't have touched her, but I don't do these lid surgeries anyway, nor would I have referred her. So I get to know my patients way too well. A lot of my patients are, fortunately for me, very loyal and have been with me for years. But I'm not against asking somebody to go get help, because I really would not have done this. And there's nothing, she's actually in my opinion, prettier in the first picture.
Mm-hmm.
And you did everything you could because, you know, in the second picture, she obviously is like scarred and a disaster and was feeling almost suicidal. But she needs, I don't know what cocktail of psychological drugs to make her feel better, but somebody needs to address her body and her face dysmorphia with her before she really hurts herself. The fact that she has the audacity to tell you, could you go in and take them out, means that she's still not right, and she might go find somebody else and scar herself up again. So not only should you have her sign the adverse events form that I just text you, from me, and you can change it, but the two thing you should do is you should get her to a psychiatrist for a cocktail. And then anytime she wants to do, like I tell my patients, anytime you think you want to do a procedure on yourself, you need to come ask me for my permission first. And so, you know, and my patients trust me, and a lot of them, they like the way that I'm aging, so they're like, okay, Dr. Downey, I'm a little heavy-handed, but I'm sweet, and they know I really do care. So, you know, but I think she needs to, like, get a gateway of permission before she does something.
Actually, one other legit comment. Suppose, take away all of the other factors in this patient from a psychiatric standpoint. Suppose it's someone different who, for whatever reason, has legit concern about her lower lid position, and you want to do something, but you really feel like surgery is not appropriate. An article was just published on this, and something we've been doing for years, using exactly what you did, using Restylane or High-G Prime filler, HA filler, to get a little bit of elevation of the lids, injecting anterior to the septum behind the orbicularis. You can get a little bit of elevation. And if someone really was pushing for it, and you wanted to get a bit of vertical elevation lids, you can use HA filler for it.
Yeah, no, that's a good point. I think you can use fillers, especially hyaluronic acid fillers, to your benefit. I will say one thing, for many years, and I still sometimes do in select people, I do inject the lower lid exactly in that plane. And I will say that I was humbled. I presented this for many years, and in those small quantities may not be an issue, but there is a potential plane there. And when you microbead, as opposed to the tear trough, but when you are injecting HA in that plane, meaning preseptal post-orbicular, just realize that the filler bleed is a real issue. So if you have someone with impending malar bags, you may just do them in, and they may never be able to get rid of it. Because over time, injecting in that plane in the lower eyelid, there's some seepage, and it really was humbling to me, like 5 to 10 years later after my own injections, where I presented this microbeading process at Baker Gord, everywhere, to see some of these patients come back with this seepage. And so just be careful. So for those patients, now I really screen them, I really follow them very closely, and if I see that they have any kind of history or malar bags, I don't do that procedure in them, or like you said, just very small amounts just to correct the canthus. I just want to, because I feel like, what did I say, all complications happen after you go to meetings, because you hear everyone and you just want to try everything.
Right.
Which is, last thing before maybe you want to present the rest of your presentation is, I just wanted to mention something about tox and in the periorbital area, and hopefully Dr. Weisman or anybody can. I just feel like people think that a crow's feet area is a very forgiving, easy area to inject. And again, we all go to meetings, and and also in our office is easy. The dosage is pretty easy. You see the pattern. I find that it's every time I inject the periorbital area, it's a challenging case, because you have to assess patients for dry eyes, for lower lid position, for orbicularis tone, and please, obviously we all need to know where we're injecting. Are we in pretarsal? Are we in orbital orbicularis? Because I have seen people with lower lid malpositioning. I have seen people who start tearing. Do they have a malar bag? Remember that the lateral orbicularis is the pump, obviously, for the lymphatic drainage. So if someone has an impending malar bag, I have had patients who become crippled by that. And so it's very important. So I feel like a lot of people think, especially extenders think, it's an easy area to inject around the eye, but between the brow, the lymphatic drainage, the muscle, the blink muscle, it's the position of the lower lid muscle, it's
Possibly
everything.
Going a little lower and getting a little
So
bit of
really
zygomaticus.
be very careful with that. And in some people, you knock off those last receptors, and they end up, now they need to get a spacer, they need to have oculoplastic surgery to reposition their eyelid. I've seen all this, because now I've, of course, been in practice for 25 years, so I'm humbled by all that. So I just wanted to put that out, because we did discuss tox and orbicular area, and we were going to discuss it in the thing. Thank you. Yeah, I'm going to let Dr. Haas. We can
I'm curious, I want to know what you were going to say about it. So.
No, my comments about exosomes is that they're the new kid on the block, and I think we all are in technology. We all want to use new things and really understand them. Again, I'm a surgeon. My brain is always programmed to think about the worst thing that can happen and what can I do to prevent it from happening every time I go into surgery. Exosomes, we do use exosomes. I think that people are jumping a little bit too fast on the bandwagon, not because there's not evidence-based stuff yet, because I'm more about evidence-informed procedures, but I do think exosomes, as you know, have cargo in them. It's the cargo that's important, right? Exosomes are cell-to-cell communication modalities, and there's DNA and mRNA, and as you know, mRNA can be transcribed. So I urge every one of you, when you look at exosomes, to know where the exosome comes from and make sure you understand what is in the cargo. If the manufacturer can't tell you what's in the cargo, I would not probably lackadaisically inject or microneedle into people's tissue, maybe use it topically, because the cargo can be transcribed, especially, human-derived exosomes, right? The cargo. So if we don't, so I think we're going to learn more about exosomes. There's some new technologies coming out for autologous exosomes that I'm involved with and I'm very interested in. So it's your own exosomes. Obviously, fat has a lot of your own exosomes in it. But I just think that we're talking about all this stuff, but we just have to be also careful, not because I'm thinking, oh my God, maybe there's a horrible thing in all these exosomes, but what if, right? What's the worst thing that can happen? Let's just be thoughtful about it.
Yeah, and the autologous exosomes are nice.
They are nice, exactly. Yeah. Thank you so much. So anyway, that was my 2 cents about exosomes.
Okay. So we'll catch back up, but I just wanted to show, particularly Dr. Jacob. I have a set of before and afters from Dr. Jacobs, so I want to make sure I get to show this. Can you put the submental slides back up?
Your what name?
Halas, H-A-L-A-A-S. Any other questions for any of the cases that we've had? Dr. Weisman has to go to a meeting, but while we're waiting for the slides to come up.
In terms of questions, there's one from the audience right there.
Yeah.
I took HelioCare this morning. I have really severe melasma. I'm an ex-lifeguard and ex-swim instructor and a complete tomboy. So I will get like a man's mustache, and my joke is, I got a man, I don't need to look like one. So I use the HelioCare. I put sunblock on. I haven't put it on today, like, besides like my reapplication in the bathroom before. I should have put it on when I was standing outside, but I was so annoyed about cutting off this thing. But I'll literally put it on about 6 times today. I use the Powder Puff, the Color Science. I also recommend the Isden. And then I have a cream sunblock. I have the Total Defense and Repair in my bag. And then I also use the ZO. So I use a wide variety of them. Isden, Aerofitona, I like a lot also. So I like Total Defense. I like the ones that are for UVA, UVB, anti-infrared, and anti-HIVL. I need all 4, and that's face, neck, and the backs of my hands. And then I actually have sunblock on my legs. I have like Aveeno or Neutrogena on my legs and my arms. And my vitamin D level is fine.
Okay, so we were just going to get into how we can use technology to achieve some of the improvements in the deep tissues of the neck. So using somebody actually came up. It was a CME talk, but we're so off now. I'll use name brands. So if we use FaceTite, for instance, and use a percutaneous suture, you can use my Elevate. There's also you can come up with your own dissolvable version. You can get improvement. You can get tightening. But which layers are you dealing with? Then you're dealing with the subcutaneous fat, but you can get some elevation of the deeper tissues. You can intervene with the muscle. But the question would be, how much are you getting of that submandibular gland malposition that we develop as we age? Another example. And here is next. I can't move it. If you can move it to next. There we go. Okay, so this patient, not performed by me, had a facelift, and as you can see by their pixie ears, was pulled as tight as could be humanly pulled, to the point beyond. And actually came to me not because they are upset about the pixie ear, but that wasn't really the problem. That maybe they'll say in a couple of years they'll deal with that. But was really just so bothered by the submandibular gland malposition. And with technology, you can get some improvement of that. But yes, all of us could be wondering, why on earth is he so concerned about that little bit of submandibular gland when you have in the face of a pixie ear? Because people just want to be as tight as they possibly can. And with technology, you can make a difference. A lot of us are using, and I had put the brand names in, a lot of us are using fractional RF and ultrasound technologies so that we can get improvement. And then you can modulate. You can go for the skin. You can go for the fat. And then the question is, how much are you modulating that platysma? How much are you actually modulating? Platysma is this mass, so are we actually making a modulation there? And is this because we're improving tightness on the skin, or are we really getting to those deeper levels to make a profound change? But particularly on a younger patient, when you don't have that malposition of the hyoid bone, and you don't have that submandibular gland ptosis, you can get pretty remarkable results. So there is a new technology, and I and Dr. Jacobs, who's in the office, who's in the audience, there is a new technology that can actually work to modulate not only fat using radiofrequency, but also muscle stimulation to go on. Kind of what we're hypothesizing is that you're getting a digastric not a hypertrophy, but actually a digastric ptosis, which is kind of an interesting point because we really haven't been thinking so much what is happening with the muscles as we're aging of the neck. We have some idea with zygomaticus major, with frontalis, you have decreased signal as you age. The muscles just aren't working as well. They're not functioning. Their basal tone, we see that with a frontalis muscle, our basal tone just kind of collapses and is, if we do EP signaling, you'll see that it's actually less, and that's why we're getting dropping. And what do? We hyper move so that we can overcome the ptosis that we see in the brow. Is this occurring in the neck also? So here's just a couple of examples, and importantly, next, I just want to show you, is that you can see on MRI, you see not only a decrease in volumetric fat, but you also can see a significant repositioning of the hyoid bone and the digastric muscles. So I think this is a very interesting and a very new tool that we can use for the challenging area of the submentum. Next. Next, so, but actually, not when you can actually kind of, go back for 1 second. So there you can kind of see how theoretically that positioning is happening. You can see the bowing of the digastric muscle. So if you contract and you tighten it more, then you're going to be holding yourself up into a better position. Next slide. So using RF, this we know. Next. The importance is that you're using RF at a higher temperature so that you can get penetration. We don't need to have such high RF when we are just looking to get changes in the skin, but to get modulation in the fat, you do have to go higher. Next. And just proving on histology that we're able to do this. Next slide. Let's just go quickly. Next slide. You can see you're actually getting true changes in collagen content as well as true apoptosis. Next slide. And so this is the kind of, obviously you're not going to be achieving what you achieve with surgery, but you can get a 30%, and that's just in 4 treatments. You can get a volume reduction and change in about 6 cc's of volume reduction in the submental area. Next. Yep, and then just some before and afters. And just next slide again. And this is Carolyn's slide. But you can see a true improvement, and what's interesting is before, when we were just looking at the submentum, we know that there's some fat there, we know that there's some skin there, but we really do want to be thinking about that hyoid position and that digastric muscle, that truly unfavorable anatomy. Where is the hyoid bone in the neck, so that you can modulate and treat in a way that's going to be appropriate. And I think there's some more before and afters, and I have a couple more slides, but that was, after that enormous break, the exciting conclusion to what we were talking about today. Thank you.
Thank you so much.
Thank you guys so much for hanging with us, and we really appreciate each and every one of you that came back. Have a great day. Rate us highly if you liked us. If you didn't like us, don't say anything. Just kidding. All right, take care. Thank you guys.
Take care.